After joining the Mount Forest Family Health Team in late 2012, Elsa has quickly stepped into the role of team leader of the Rural Wellington Community Team, where she has been for the last 9 years. And she has been described as the glue that sticks the harder to serve in the system. The team works there to support community members and for those who have become completely disconnected from formal and informal support systems. So thank you, Elsa, for joining us today, and our thanks to Suzanne Trivers, who generously identified your work and is currently on the board with the Rural Ontario Institute. So thank you again.
Thanks very much for having me. And I was a last minute addition to this agenda today, so if anybody needs to at this point in the day get up, stretch, and go get something to drink, I will not be offended at all. But I would like to take about 15 minutes, and if I can curtail my slides to something that's a little bit shorter. I do have a little image slideshow at the end to have you watch while you ask questions about anything that I've presented. So without any further ado, I'll just jump in. So feel free to get up. So as mentioned, I've been in this role now for a period of time. I can't believe it's been this many years, and I can't believe the team has been on the ground for this many years already. When my executive director first approached me about this idea, and she loves this story, she gave me a little drawing. It was like a circle with some like arrows going into it, and she said, so like we've got people and they're not connected to services, and the physicians and primary care providers are really worried about them. And she drew this circle and these sticks and said, can you kind of put something together like that? And I said, I think you're going to need to give me a little bit more information on that before I get started. But lo and behold, 9 years later, we are an ever-evolving team. I don't pretend to say that we have it all figured out, but I will say that we have learned a heck of a lot along the way. So, oops, how did my slide go there? My animations aren't working. Anyway, you can get it all at once. It'll make the slideshow go faster. So, the Rural Wellington Community Team is something that formed back in 2013, me in the team lead role, and currently with 6 other outreach workers that are on that team. Those workers work across the entire geography of rural Wellington. They are not attached to one family health team outside of Mount Forest that acts as our employer, but we are a regional support. So wherever the need is, we go. If we need more time and more outreach workers in one area at any given time, then that's what we do. So the 4 family health teams that are in our geography are Minto and Mapleton, the top arrows there. Wellington North is the one at the top, which includes Mount Forest Family Health Team. And we also capture the bottom half or bottom part of Southgate Township. So that also, because it fits in our LIN or OHT. And then Center Wellington, which is where Upper Grand Family Health Team is. So those are the communities of Elora and Fergus and Bellwood. And then into the east and southern part of just above Guelph there, which is Guelph, Aramasa, and Erin Townships, which is East Wellington Family Health Team. We are all part of the Guelph Wellington OHT now moving forward. What I wanted to point out was that of those that serve this geography, let me just see where we are. This is going to be a little awkward because I have reading glasses on. So the whole focus of what it is that we do, I'm just realizing my slides are out of whack there. There we go. The whole point of what it is that we do is individuals that have been in our community that don't have help in any other way. They don't have a family member. Somebody had mentioned, can't remember who was presenting, who said, talk to the daughter. You have a key person in your family or in your world that you tend to go to when you have an issue. And some people don't have that person. And it may be somebody different for you at different stages of your life, but the people that are coming to us typically don't have that person to navigate things with them. For the most part, they're individuals as opposed to families, although we do have families that get referred to the team as well. But they just have a hard time navigating the system, and I know that kind of gets a real blanket statement in terms of navigating. But our system's complicated. And for those people who don't have a skill set for understanding process or steps or, call in, dial 9 for this, for, your worker directory, spell the last 3 digits of their, that sort of thing is not the people that we tend to support. Those people that need help navigating those things are who get referred to this team. So the workers that we interviewed for these roles were, they're not full peers in that they have no education that goes along with this role. They certainly do. But we kind of hit a sweet spot. We hired people who had experience in social services or other areas, and that might be child protection or criminal justice or corrections or addictions, all sorts of different fields. But they also had firsthand lived experience either navigating the system for themselves or somebody in their world. And they also had a rural lens. So we wanted somebody who was going to be able to kind of get in there, understand what people are going through, and really kind of hit that mark in talking to them right away. Not that they were there to divulge all their own personal stuff, but just to say, I get it, and really resonate with those people so that we could build that rapport as quickly as possible. So, again, my animations aren't working, but anyway, I have to catch myself up. So one of the things that we're quite skilled at and built up over the years is that, as was said, we stick the hard to serve to the resources that they need. So that might look like community service agencies or mental health groups or even resources within the family health team that we work in. Even connecting people to those resources can be challenging, so we take an effort to do that as well. All those social determinants of health that we've been talking about today, those income supports, that housing search, that housing maintenance, maintaining that place, advocating for yourself, standing up for yourself, domestic violence situations, all of these sorts of things are things that we help walk people through. And the top point there about collaborative work with community partners, there was an interview or a questionnaire that went out probably about 8 years ago with our community partners and asking what was the most significant difference that was made in our community over the last however many years, and somebody pointed out that the introduction of this outreach team, because it is a flexible and nimble team, has really made an impact. When we have really strict criteria and categories for people to participate in things, it makes it that much harder to get things done. Shifting somebody from this resource to that resource. Oh, you turned 18, now you have to go here. So having this flexibility has really made a difference. So just some of the things that we tend to connect people to, I'm just reading out a little list here. So some of our community partners, CMHA has a very close working relationship with this team. We actually started out with a CMHA worker on the team, and then we shifted to a kind of only outreach worker role on the team, and we built a better pathway with CMHA to work instead of having a worker on the team. Ontario Works, in our rural community, we really know all our workers by name. So we can pick up the phone. We always say, we've got you on speed dial. So a lot of these organizations, like our community resource centers in the community, Ontario Works, ODSP, a hoarding network, we have a situation table in rural Wellington, our impact team, which is our mental health and OPP working team. We have our GEM nurses in the hospital social workers in our rural hospitals, our Guelph Wellington Women in Crisis, RAM, Sanguine Vans, Legal Clinic Van, you name it. We connect really well with them. We know who to go to for what, and that is a really beneficial thing for when we're suggesting things to individuals, because we're not leading them to the wrong door, which gets really frustrating. Go on here. Okay, so what exactly do we do anyway? We take time to listen to what's pressing for the individual, and we do that in a trauma-informed and a person-centered way. Clients share openly with those that they feel comfortable with, and because we are people, we like to say, we tend to get a lot more information than they might share with primary care. I will give you one short example. I helped a patient put together an ODSP application. This was their third time through putting an application in, and they just were getting denied. And again, a lot of mental health criteria in there, and a lot of those symptoms that are hard to identify what the cause is. And they said under their breath, they said, is there anything we're missing in putting in this application and telling your story? Well, there was that time I got stabbed. And I said, what? You got stabbed? And the patient shared this story about how they had been assaulted. And I thought, does your provider know this? And they didn't know. And so we went back to those dates and we put all that information in there. And sure enough, I Googled it and there was the report. So those sorts of things are things that are shared with the team that for other reasons and not a fault of the provider. I mean, sometimes you don't need to get into those deep conversations with primary care. So this role allows for more time for that sort of thing. So sometimes when they're putting together their things that are most important to them that they would like to work on, it's not jiving with what primary care wants them to work on or what primary care identifies as being most significant for their health, but we have to start somewhere, and it's important to start where the patient feels is most important to start. So that's where we start. Again, as I said, because we have the knowledge about the services that are out there, we can provide options and let them direct what the activity will be to address that goal going forward. I use the word leverage. We get to leverage that rapport to help move them down that path. And yes, it might not be comfortable, as we were kind of hearing in earlier presentations, it might not be within their comfort zone to try doing some of those things, but because of the trust they've built with us, they're willing to try. So we actually chart right in the medical record. That was something that was important right from the get-go. We wanted primary care to be the hub of all that information. So all of that is in the medical record. When we have an appointment with an individual and we help work them towards their goals, it's not like primary care is reading each and every note, but when there's something notable, you'll be sure that we're going to be messaging the provider about that to keep them in the loop, especially if we know that there's an appointment coming up. So being part of that circle of information sharing is really, really helpful. And then when we put our goals together, we actually place that in the ministry's coordinated care plan tool. Love-hate relationship some of us have with that tool, but it's the best tool that we have right now to kind of capture those goals, who's in their team right now, helping them to achieve those goals, what is all that contact information, what's their plan and their activities going forward. So that is captured in that tool and again embedded in the EMR. And then at the end of every visit, we ask the question, was this helpful? And it helps to guide us in terms of being a better worker. Because sometimes they say, look, I was just really frustrated. I need to come in and talk to you. I really wasn't ready to go on to my next activity or whatever. But asking them if this is helpful is a good practice. So, where am I here? Go. So anyone can refer to the team. Our two criteria, which is pretty loose, but we had to have some criteria, is they have to reside in Wellington County or they have to be a rostered patient to primary care that exists in Wellington County. Because we can't be all things to all people, and the further afield they live from Wellington County, the harder it is for us to support them. It's not to say that if a patient isn't a patient in the Mount Forest Family Health Team and they reside, say, in Collingwood, that we can't support them. We can, but that tends to look a little different. It's less community-based, it's more virtual, and it's not in their best interest for us to be their main support. They need somebody who's in their community to be their main support. So we work with them until we get them connected closer to home. Like I said, flexible about access. So we don't actually have reception. We have a cell phone. Before COVID, we were texting, and I was pretty avant-garde, and now, look at us, we're all texting. We're all emailing with patients. We're all having that correspondence go back and forth, and the sky has not fallen. With a lot of the folks that we support, their cell phone is their only connection to support and to service, and at about day 15, the minutes are gone. So if they can't text us, then they have no way of connecting with us, because at that point they're already at the Tim's or the local coffee shop somewhere, the library, trying to access an internet connection in order to make that contact. So we have to be flexible if we want to support these folks. Some of the things that are really important on our agenda is to build capacity in those individuals. We're not there to kind of be the answer every single time something comes up. We want to help them to identify somebody in their world that they can trust or build trust with to help them when they get stuck going forward. We want to help them to recognize that they have transferable skills. If they have had success in this situation, they've called their ODSP worker, they've understood how the phone mechanism works to finally find their worker, that they know that when they call somewhere else and it's the same sort of system, they'll be able to do it. So we do a lot of cheerleading that way as well. It's, you got this, you've done this before, you can do it. If you get stuck, call me or let me know how that goes. We'll just leave it with them. So we really try and build capacity in them. So some of the things that we've heard from primary care and from our clients are I know from, and we talked about this earlier today as well, primary care often is a little bit hesitant to ask questions. What do you do with the answer? If you don't know what the pathway is, or if you don't know what the next steps are, you feel less skilled at addressing that situation. So sometimes people joke and say that our team for the family health teams in rural Wellington, we're considered the easy button, and then people just slap the easy button, but that's not who we are. We definitely want to be the last resort. If there is an organization or a service or a program that is better suited, we are always coaching our primary care providers as well where the better place is to go. If we have somebody that's over 65, before you refer to my team, are there any senior supports that are better suited for this individual? Because guess what? They're not getting any younger. They're only going to get older, and their trajectory and the things that they're living with are only going to get more complex. So why don't we connect them to senior supports now, as opposed to introducing them to me, and then in a year I'm going to introduce them to somebody else. So we're always trying to think practically that way. So we do refuse referrals from time to time, just so you're aware. In terms of what primary care has said, though, is that they never want to see this team go, because now they feel like they have a good resource that they can call on, either just to check out if this is a good referral, get ideas for where to send them, or actually make a referral to the team and have us follow through. And I can't tell you how affirming it is to get a referral and then, and this is going to sound silly, but not hear back from that provider. When I message them and say, yeah, I got this, they're like, oh, good. And they know that we're going to reach out when we need them, but they know that we've got the football at this point in time. They've passed it, and we've got it, and we're running down the field. In terms of patients and clients, back in 2008, we did an e-health business results exercise, and a number of patients that were tied to the team were interviewed by that. And so some of the things that are listed there was the comments that patients had provided was, I was given many options of who could help. It's nice to have people say that they're here for you. They make a huge difference in my life, and I don't know. If I don't know, the outreach worker makes it clear to me. And what that last statement just feels so good for me, knowing that if I don't know. So they're giving themselves some credit for knowing some things, but when I don't know, I feel comfortable going and reaching out to them. And that also speaks to the access piece about the team. If somebody is referred to our team, they don't, we don't disappear. In that way, we're very much like primary care. When you need us, give us a call. When you don't need us, you're fine. And so people know that they can reach out to us. The one part that I realized I didn't speak to was that in terms of who refers to us, so primarily, still, primary care is the biggest referrer to us, but then we also have individuals that are referring themselves now. We have people that were supported by us in the past who've now told friends, and they told two friends, and so on and so on. But, and so that word of mouth has really gotten more people to us. And then also community service agencies that used to fax us referrals now, because they're not in that healthcare EMR system, used to fax us referrals. Now we use an Ocean platform for those referrals to come to us. and acute care as well. So acute care mostly through social worker, gem nurses, that sort of thing. Okay, so where am I at now? I think I have time. Do I have time to do one more slide before I do this slideshow? Here we go. I'm going to do one more. Just want to tell you about some exciting things in terms of what's next before I go to that question. So we are embarking on employing peer workers to build on what it is that the outreach worker team is doing. We find that some of the people just need just a kind word, a touchstone, somebody to connect with, somebody to have a coffee with, and the outreach workers don't have the capacity to do that, but a peer worker certainly would. And in terms of what will their lived experience be that they bring to the party, it could be anything. It could be somebody who's experienced getting that diabetes diagnosis, and they know what that feels like when they just feel like their life is just flipped over. It could be any other chronic disease management, it could be addictions, it could be mental health, it could be anything. Not to replace the resources that are already out there, but just support on a different level some of those things. We are involved in the Mental Health and Addictions Working Group with the Guelph Wellington OHT. We went through an exercise this last year of putting a website together, so I'm putting it up there for you to check out as well. It's called Help Us Here Wellington. Many of our individuals that we support don't know what resources are out there for them when they're struggling, so we developed a poster that says, "Are you struggling?" And then it uses the Rush tiered model of intensive support as a guide to identify which supports are needed for what level of intervention. And so that is, and we used peers to help us develop questions for individuals to ask themselves. So, you know, I'm not coping well, I don't cope well every day, sort of thing, that sort of thing, and then there's a resource that goes alongside that. And then we've also listed in there resources that can be accessed in different ways, by texting, by calling, by online, virtual, by in-person, because everybody has a different way that they'd like to receive support, and everybody has a different skill set of what kind of support that they can seek out and participate in. And Guelph Wellington Drug Strategy, we're about to adopt a harm reduction supply chain, for lack of a better word, spreading that out across rural Wellington, wanting to engage libraries, coffee shops, family health teams. We're having a little metal cabinet put in where people can come and get harm reduction supplies. So that might be naloxone kits, that might be cooking kits, or it might be all sorts of different things. We are also embarking on food security and social prescribing programs. We're just in the infancy of that, taking lots of good information from our Guelph partners and seeing how we can transfer that into a rural context in a way that makes sense. And just received some funding for a community garden pilot project that we're starting in Mount Forest and wanting to roll out. So lots of good things. And on that note, I don't know how to start that, though. How do you start the slideshow? Anybody? I don't know how to click it. How do you make it go? Tech people? Nobody knows. Okay, it should just go. Should be a way of clicking it. Nope, that didn't work. Never mind, you don't get the slideshow. Does anybody have any questions?
Any questions for anyone?
Yep.
Elsa, where
Yes.
does the funding come from for this dynamic program?
Good question. That was a slide I avoided. Are you trying to get my thing to go? Is there a way for you to click in the middle of that? That's not working? Okay. So the funding right now flows through Home and Community Care, through the LIN. And we started along with three other, they were called in-home teams, one in Cambridge, one in Kitchener and surrounding areas, and Guelph. And our team model was a less clinical model and more of a flexible outreach model because we knew we were going to be super community-based. So we kind of went off in one direction, and those other teams are still in operation, but they are doing things in a little bit more of a clinical fashion. So that funding is actually base funding that's continuing on. And certainly the value of the team has been proven over and over, and they want to support that. So if anybody else is thinking of doing such a team, some of the suggestions were consider if you have any gap positions within your family health team, if there's any new money for mental health or addictions work, for emergency room diversion programs, that sort of thing, you might be able to make a case for something similar.
Great. Well, Elsa, never doubt that a small group of people can make a difference, because certainly you are.